Let's start with our bladder cancer immunotherapy breakout. We're joined by Dr. Matthew Galsky. He's a professor of medicine, director of genitourinary medical oncology, co director of the Center of Excellence for Bladder Cancer, and associate director of translational research at the Icahn School of Medicine at Mount Sinai in New York City. Also with us is Brian Brewer from the Cancer Research Institute, who will be sharing your questions with Dr. Galsky. So please be sure to put them in the Q&A box. Dr. Galsky, Brian, let's learn about the very latest in immunotherapy for bladder cancer.
Hi, everyone. It's my pleasure to be with you today to discuss immunotherapy and bladder cancer. Bladder cancer has the designation of having actually one of the most effective and oldest immunotherapies used to treat the disease, and that's BCG. BCG is a form of bacteria that's a weakened strain that's instilled into the bladder to treat non-muscle invasive bladder cancer. This was developed in the 1970s by Morales and colleagues, and actually became an alternative to surgical removal of the bladder for non-invasive bladder cancer. That's a fact that's frequently forgotten, but this really became an incredibly effective therapy that replaced a surgical therapy for definitive treatment of non-muscle invasive bladder cancer. So a very effective immunotherapy, but then there was decades that passed with very few advances in the treatment of bladder cancer. And this didn't only apply to immunotherapy, but to other systemic therapies as well. And actually, for a greater than 30-year period of time, there was only one new drug approved by the FDA for the treatment of bladder cancer, and that was a chemotherapy that was instilled into the bladder in patients who had received BCG therapy, but BCG didn't work or stopped working. For the treatment of advanced bladder cancer that had spread beyond the bladder, platinum-based chemotherapy, chemotherapy with drugs like cisplatin or carboplatin became the standard treatments, and really remained so for many decades, again, with very few advances. And those treatments can be effective in a subset of patients, but they don't work in everyone, and they stop working in many patients, really highlighting the need for additional treatments for this disease. Things really started to change, though, in 2016, and that's when immune checkpoint blockade, PD-1 and PD-L1 inhibitors, were developed for the treatment of other cancers, and in early phase clinical trials, it was quickly noted that patients with bladder cancer responded to these treatments favorably, with a shrinkage of cancer, even cancers that had spread, with control of those cancers in some patients for what could be a very prolonged period of time. So based on the lack of treatment options that were available, based on the fact that PD-1 and PD-L1 inhibitors worked in a subset of patients very well, and based on the fact that for at least a subset of patients, these treatments are well tolerated, PD-1 and PD-L1 inhibitors were rapidly developed and approved for the treatment of metastatic bladder cancer, particularly, or at least initially, in patients who had received chemotherapy and then chemotherapy stopped working. And there were actually 5 PD-1 and PD-L1 inhibitors approved for the treatment of bladder cancer in that setting over a 2-year period of time. So with that rapid drug development, the logical question became, can we use PD-1 and PD-L1 inhibitors in other clinical disease states of bladder cancer? How about moving these treatments earlier to see if we could have an even bigger impact on the disease? And the next most logical place to take these medications was for the initial treatment of bladder cancer that had spread in a subset of patients who can't safely receive the drug cisplatin because of other medical problems. Historically, that's been a difficult to treat population and an unmet need. And there were 2 PD-1 or PD-L1 inhibitors approved in that setting, and really represented moving these treatments earlier in the course of the disease. The next step, though, however, was to determine whether or not in the treatment of patients with non-muscle invasive bladder cancer, a very early clinical disease state of bladder cancer, whether or not these therapies are effective. And pembrolizumab was studied in this population, a PD-1 inhibitor, shown to be effective and ultimately approved by the FDA. This was followed by a series of additional large clinical trials trying to further refine the use of PD-1 and PD-L1 inhibitors in bladder cancer. And what's really evolved is a common treatment strategy in this disease, which is a bit different than what we see in some other advanced solid tumors, is that instead of giving chemotherapy and immunotherapy at the same time, which has evolved as a very common treatment strategy for cancers like lung cancer or breast cancer. In bladder cancer, it seems that giving chemotherapy initially when patients have bladder cancer that has spread, and then switching immediately to use immunotherapy afterwards results in a beneficial effect. And that's really become a preferred treatment strategy over the past few years for the treatment of patients with metastatic bladder cancer. The next series of advances, though, really focused on whether or not we could give combination treatments that even increased the likelihood of patients benefiting from treatment further. And one of the combination strategies that's really shown the most promise to date is the combination of a new class of drugs called an antibody drug conjugate in combination with immune checkpoint blockade, with PD-L1 blockade. And the antibody drug conjugate in question here is a drug called enfortumab vedotin. This is a protein, an antibody, that's designed to bind to a protein that's expressed on cancer cells called Nectin-4, and it has a chemotherapy drug attached to it. So the idea here is that one could selectively deliver, by using this antibody targeted approach, selectively deliver chemotherapy to cancer cells and try and avoid normal cells. This is the so-called magic bullet that cancer drug developers have been talking about for decades. And with advances in technology, it's become a reality that selective chemotherapy delivery using this approach can be accomplished. And there are a number of antibody drug conjugates being approved for the treatment of various diseases. So this antibody drug conjugate, enfortumab vedotin, was approved for the treatment of bladder cancer on its own in patients with metastatic bladder cancer, and then subsequently tested in combination with immunotherapy, really leading to some of the highest likelihood of tumor shrinkage with a medical treatment that we've seen to date in bladder cancer. And so this regimen is now being explored in definitive clinical trials to see if it should be used as standard treatment for advanced bladder cancer, and whether or not it should actually be used earlier, prior to surgery or after surgery in patients with bladder cancer that's invaded into the muscle layer. The most recent advance in the treatment of bladder cancer with immunotherapy is probably what's happening in the muscle invasive bladder cancer setting. For bladder cancers that have invaded the muscle layer of the bladder, a standard treatment is surgical removal of the bladder. And we know that with surgical removal of the bladder, a large subset of patients are cured. But in some patients, unfortunately, there is a recurrence of the cancer months to years later. And so we've always been looking for approaches that could mitigate that likelihood of cancer coming back by eradicating microscopic spread of cancer. And historically, there have been limited approaches that have shown benefit in this setting. Chemotherapy does show benefit, but even with chemotherapy, there are some patients who have recurrence of cancer. And so immunotherapy, the PD-1 inhibitor nivolumab, was studied in a large randomized clinical trial in patients who had had their bladders removed, randomizing patients to receive this treatment afterwards or to receive a placebo. And in that clinical trial, receiving this immunotherapy for a year after surgery resulted in a significantly lower likelihood of the cancer coming back, with this treatment ultimately approved by the FDA. Currently, there are a large number of phase 3 studies trying to refine the use of immunotherapy, either as a single agent or in combination, both for the treatment of metastatic bladder cancer and for the treatment of bladder cancer that has confined that's confined to the bladder, by giving these treatments before surgery or after surgery. And we'll have results available from several of these trials within the next 12 months, really poised to change the way that we treat bladder cancer. So lots of drug development in this area over the last several years after a very long period of time without significant advances. Most of this has been spurred on by the development of immunotherapy by immune checkpoint inhibitors, and lots of promise for improvements in outcomes in the future. Thanks for your attention.
Thanks so much, Dr. Galsky, for that. It's very exciting to hear that immunotherapy is making some inroads into muscle invasive bladder cancer. You said a lot in that 10 minutes there, so I would like to just dial back a little bit. Let's first talk about stage of cancer and at what stage is immunotherapy an option or something that someone should explore.
So, immunotherapy, broadly classified, is an option for virtually every clinical disease state or every stage of bladder cancer right now. BCG is an option for patients who have not received any treatment who have non muscle invasive bladder cancer. Immune checkpoint inhibitors are an option for patients with non muscle invasive bladder cancer who have received BCG already. Nivolumab, a PD-1 inhibitor, is an option for patients with muscle-invasive bladder cancer who have had their bladder removed. And immunotherapies like PD-1 and PD-L1 inhibitors are approved treatment options for bladder cancer that has spread. So really, across the whole spectrum of the disease, immunotherapy is playing an integral role.
You mentioned removal of the bladder, which we know is obviously very invasive and has long-term effects on the patient's quality of life. Does immunotherapy offer a better approach?
Immunotherapy might offer a possibility that in some patients, muscle invasive bladder cancer could be treated without surgical removal of the bladder. Right now, these approaches are investigational, but there are a number of large clinical trials exploring the combination of chemotherapy, immunotherapy, and radiation as a curative strategy for muscle invasive bladder cancer without surgical removal of the bladder. And a smaller subset of studies focused on determining whether or not resection of a bladder tumor through a scope with giving chemotherapy and immunotherapy, or even possibly immunotherapy alone after that, as a curative strategy for a subset of patients. So I think these approaches are coming, and we just need more data.
Well, that brings up a very interesting topic, that of personalized medicine. And I know this is an emerging field in immunotherapy where doctors can look at a patient individually and determine or maybe potentially predict how they would respond to treatment with immunotherapy or other treatments. Where where are we with that in terms of if you have a patient coming in who might be eligible for a bladder removal? Is there a test that can be done that can say, well, let's try this other approach first?
Right now, unfortunately, there's not. And it's not for a lack of trying. There have been a number of studies in bladder cancer specifically, and then, of course, across all tumor types, trying to determine whether or not there are features, tests that can predict whether or not patients will respond to immunotherapy or not. And this has been a complicated field. And one of the challenges in this field has not been that tests can't be developed which increase the likelihood of response to immunotherapy, because in fact, there are a number of tests that can repeatedly show from study to study that there is an enrichment in the likelihood of response when this test is present, for lack of a better term. The challenge, though, has been that if the test isn't present, there are still patients who respond to the treatment. And so it's not that tests can't enrich the likelihood of benefit per se. It's that even if the test isn't present, there are patients who benefit. And so it's very difficult then to use that tool for clinical decision making.
Well, so no test yet, I hear you say, though there's certainly a lot of work ongoing to find that. So that's wonderful. You also mentioned in your talk at the beginning that there might be different points at which a patient is being treated to give immunotherapy that might be more advantageous. So before surgery, after surgery. Can you say more about that?
Ultimately, those decisions need to be driven by data, by level one evidence, randomized clinical trials. So we're limited in part in answering that question to the data that's available at hand. Currently, we don't have the results of any randomized clinical trials using immunotherapy prior to surgery for bladder cancer, that is, prior to surgical removal of the bladder. We do have randomized trials using immunotherapy after surgical removal of the bladder. So, right now, the correct answer is to use immunotherapy after, because that's where the evidence is. That's not to say that giving it before might not be better, and ultimately we'll have those answers.
Does research in other forms of cancer inform what you're doing in bladder?
There's no question that research in other cancers informs what's happening in bladder cancer. And in fact, there are some tumor types that are a bit more common than bladder cancer where drug development, clinical trials exploring immunotherapy were initiated earlier and have completed sooner. And so we're learning a lot from these other fields. But one of the important lessons from that is that even though there are some similarities across tumor types, they're not identical. And I think a prime example of that is what's happened in bladder cancer for the treatment of bladder cancer that spread. In most tumor types where the strategy has been tested of giving chemotherapy and immunotherapy at the same time, that's been a beneficial strategy. Lung cancer, some GI cancers, breast cancer, it tends to be a common, it tends to show a benefit across those tumor types. In bladder cancer, that's been more difficult to show. And without going into too many details about some of the nuances of those studies, what has been shown is that giving chemotherapy and then switching to immunotherapy right away in what's called a switch maintenance approach is beneficial. That's a strategy that's not used in other tumor types. So, yes, we're learning a lot from other cancers, and we've repeated some strategies, some clinical trials exploring strategies explored in other tumor types, but that hasn't necessarily translated into what's worked in bladder cancer.
Fascinating. So these are questions that were submitted by people who have registered for this event and for past events interested in bladder cancer immunotherapy. So I want to thank all of you for sharing your questions with us and having this opportunity to speak with Dr. Matthew Galsky about this bladder cancer and about immunotherapy. It sounds like there's a lot of really exciting progress. So let's get on with the questions while we're at it. You also talked about combination approaches. I'm hearing a lot about this, where there's a chemo plus immunotherapy, or there's an antibody drug conjugate you mentioned plus immunotherapy. Why is combinations an area we're looking at right now?
Combinations are such an important area for a few reasons, which are related. One is that immunotherapy, PD-1 and PD-L1 inhibitors specifically, when those are given as single agents, given by themselves to treat advanced bladder cancer, say, we know that those treatments can work really, really well, but in a subset of patients. So the question is why? What is it about those tumors that aren't responding well? And can we give a second drug or a third drug along with PD-1 and PD-L1 inhibitors to increase the likelihood that there will be benefit by modulating the tumor in some way? And so that's why there's so much excitement about that approach and so much research into that general strategy. But this really harkens back to principles of drug development and oncology. In some other diseases as well, like infectious diseases. And one unifying theme for curative strategies using medications has been to use non-cross resistant medications to enrich the likelihood that cancers that aren't responsive to one drug will be responsive to the other drug. And when you give drugs in combination, you just increase the likelihood that the regimen that you're giving will kill cancer cells that are resistant to one drug or another. This is a principle of oncology that's served us well in the past and that we continue to focus on as new drugs are developed.
I know that sounds a lot like throwing spaghetti at the wall, but in fact, these trials are designed with a lot of data, a lot of research, and a lot of rationale involved in why you should use certain combinations. So that's very helpful. Thanks for sharing that with us. Do you think if a standard of care, for instance, is surgical removal, chemotherapy, is there something that immunotherapy can do to everyone knows about the side effects of chemotherapy, right? We dread them. Is there a potential to reduce those side effects if you're doing this kind of multi-pronged attack?
So when we give drugs at their standard doses in combination, then typically there are the side effects of those individual components that can occur. That is the challenge of combination therapy, that there is a risk for more side effects the more drugs that you give. What we hope to not see, and why this needs to be proceeded carefully by doing well conducted clinical trials, what we hope to not see is a synergistic effect, an exacerbation of the side effects of one drug by giving it in combination with another. And we haven't seen that necessarily with most PD-1 and PD-L1 inhibitor based combination strategies to date. There are some where that has been seen and those haven't moved forward, but for the most part, what you get is the individual components of the regimen contributing to the side effects.
So you're not seeing, or where you do see, as you said, an exacerbation, things get worse. Those are stopped. Those combinations are stopped in the I guess early phase toxicity studies, and at the same time, we're not really necessarily seeing fewer side effects, but you're seeing classical. I think that's something classical side effects, and that's something a lot of people don't understand about most clinical trials. Some are highly experimental, but some are also involving drugs that we already know quite a bit about already, but we're testing in new combinations. Um, People don't really understand, why they should enroll in a clinical trial. So if someone has muscle invasive or whatever you tell us what's the stage of bladder cancer where someone should start looking at an immunotherapy option. When does that happen?
So a clinical trial should generally be considered any time a treatment decision needs to be made in terms of cancer treatment. And that can be the very first decision, and it can be after treatments have been administered in the past. For every decision, there is commonly, not always, but commonly a clinical trial trying to optimize the care related to that clinical decision. So a clinical trial should always be considered. Every drug that we spoke about today, every FDA approval was approved based on a clinical trial that showed a favorable balance of benefit versus risk. And patients had to enroll on those trials to generate that data to lead to these advances. So we have no advances in the treatment of this disease without clinical trials.
Are trials right now one of the better ways for patients with bladder cancer to get access to these treatments, or are there other ways they might be treated with immunotherapy or combinations?
Immunotherapies are standard treatment for bladder cancer across the spectrum of the disease, and so they are available as standard treatments given within the realm of the specific scenario across many different disease states. There are some situations, though, where they're not yet standard of care, like giving treatment with immunotherapy prior to surgical removal of the bladder. That's called the neoadjuvant setting. That's not yet a standard treatment strategy. It's being explored in large randomized clinical trials. And so to gain access to an immunotherapy in that setting really requires participation in a clinical trial.
Is this an option that patients are made aware of early on? I suppose it depends on where they're being treated. How about in your care? How frequently do you mention clinical trials to your patients?
So I think you're right. I think it depends a little bit on the location of care. I think it depends a little bit on um, how plugged in a patient is with advocacy organizations and seeking out treatment options for their disease. And so sometimes people come to me and say what clinical trials are available, and sometimes my bringing up a clinical trial is the first time they've heard about clinical trials, and really require some discussion about what this means. We try and discuss clinical trials with all of our patients at really any treatment decision where a clinical trial might be relevant and available.
That's wonderful. And we hope that we can encourage people to ask their healthcare team about clinical trial options as well. Let's wrap up. We're almost out of time. I want to thank you again for spending your afternoon with us today to talk about immunotherapy for bladder cancer. I'm just very curious, as many of us are, how has the revolution in immunotherapy that's kind of taken place in the last decade, how has that changed your outlook on treating patients?
So I think immunotherapy, and again, speaking specifically about immune checkpoint inhibitors, it's really transformed the care of bladder cancer since I've been caring for patients with bladder cancer. Unfortunately, these treatments don't work in all patients, and that's what we struggle with, and that's what we're trying to optimize. But when these treatments do work, they really work in a way that's different than treatments that we've historically had to treat this disease, and so really have been transformative.
Well, that's encouraging to hear. Well, that's all the time we have. I want to thank you for giving us an update on bladder cancer immunotherapy and for responding to the questions that some of our audience have submitted. And I'm sure this is an intense area of interest for all of them as well as us, and I'm sure you. So thank you again for all you do, Dr. Galsky, to save the lives of more patients with immunotherapy.
Thank you.